A very good evening, a very warm welcome. Myself, Aishwarya Nair, welcome you all on behalf of the Pharm D Community for today's session on ulcerative colitis by Dr. Neeraj Vinayakumar, sir. I'm thankful to all the participants who have joined us on YouTube for taking out their valuable time and for attending this evening talk. Pharm D Community has been created with a charter to provide free webinars by doctors and Pharm D doctors. We conduct these webinars solely for the purpose of pursuing interest, facilitate, and foster awareness and education in our chosen field of pharmacotherapeutics. Organizing this event would not have been possible without the help of the core committee members and the newly joined Pharm D community members. I would like to thank everybody. I would also like to thank all the government officials and our speakers for supporting us through this socio-educational cause. Our upcoming lecture is tomorrow, 20th February. Kindly note the timing is in morning, that is 11 a.m. So kindly make a note of the timing. The timing is 11 a.m. Usually our lectures are in the evening, but since it's a Sunday, it's in the morning. I'm thankful to our speaker for today, Dr. Neeraj Vinayakumar, sir, who is one of India's eminent gastroenterologists. Dr. Neeraj Vinayakumar, sir, has completed his MBBS and MD from Trivandrum Medical College. Sir has completed his MBBS, MD Medicine, DNB Medicine, DM Gastroenterology, DNB Gastroenterology, MRCP UK, and MNAMS. Sir is a visiting consultant at Aziza Medical College, Bishop Hospital Kollam, and Ramakrishna Ashrama Charitable Hospital Trivandrum. With this brief introduction, I would like to hand over the session to Dr. Neeraj Vinayakumar, sir. Over to you, sir.
Thank you, Pharm D Community, for inviting me to have this lecture for today. So let me share my slide. Is the slide visible?
No, sir, it's not visible at my end.
No, sir.
Okay. So is it visible now?
Yes, sir.
Yes, sir, it is.
Okay. So welcome you all for today's lecture. Today's topic is ulcerative colitis. So I have around 25 slides. It is a vast topic to cover in 45 minutes. So I'll try to do my best. I have tried to include all the important points in ulcerative colitis. So let's start. So what is ulcerative colitis by definition? So as we know, it is part of inflammatory bowel disease. So there are mainly two types of inflammatory bowel disease. One is Crohn's disease and the other one is ulcerative colitis. So ulcerative colitis is a chronic inflammatory disease of the colon. So it mainly involves the mucosa. So here mucosal inflammation is the key in pathogenesis, and in most of the cases rectum is involved, and it is a continuous involvement, unlike in Crohn's disease, which is usually skipped involvement. So coming on to the epidemiology of ulcerative colitis, as you can see in the figure, the red is high prevalent, high incident areas. So that is mainly in the northern part of America, western part of Europe. So as you can see in India, the incidence is not so low. It is around 4.9 to 7.7 per 1 lakh person years. So this is the global epidemiology of ulcerative colitis. So the incidence is around 20 per 1 lakh population. Regarding the age of onset, it has a bimodal peak. So first peak is between 20 to 40 years, and the second peak is between 70 to 90 years. Ethnicity, mainly Jewish people are involved uh, compared to the Asian population. So, and the male to female ratio is female to male ratio is 0.5 to 1.5. Smoking may prevent the disease in ulcerative colitis, unlike that in Crohn's disease, and there are no increased risk with OCPs. Appendectomy has been found to be protective. There is a slight risk reduction of around 13 to 26%, and there is a slight preponderance in monozygotic and dizygotic twins. Antibiotic use in early childhood has been found to be predisposing to develop inflammatory bowel disease, both ulcerative colitis and Crohn's disease. Breastfeeding is found to be protective, and there are a few dietary factors like high protein, animal protein diet, and more of saturated fats also diet has been found to provoke inflammatory bowel disease. So coming on to the pathogenesis, there are multiple factors involved in the pathogenesis of IBD. So one of them is an altered gut microbiota. The second one is altered gut immunity, that is immune dysregulation. The third one is environmental factors, and the next one is genetic susceptibility. So there are many genes that favor the development of inflammatory bowel disease, like NOD2, NOD2, CARD15 genes, defective autophagy gene, ATG16L1. There are multiple, number of genes that are involved that make a person susceptible for the development of inflammatory bowel disease. And regarding the gut microbiota, usually in a normal gut, the number of bacteria, that is firmicutes, belong firmicutes, lactobacillus, bifidobacteria, the numbers will be high compared to the Enterobacteriaceae. In IBD population, this Enterobacteria and Proteobacteria, that sort of flora is found to be predominant compared to the normal microbiota. And regarding the dysregulated immune response, there is an imbalance between the anti-inflammatory and pro-inflammatory cytokines. So usually there is a balance. So that balance is lost. So the pro-inflammatory cytokines take over. For example, usually there are interleukin 1, 2, 3, 6, 8. Those are the pro-inflammatory cytokines, and the anti-inflammatory cytokines like interleukin 10. So there will be an imbalance between the pro-inflammatory and anti-inflammatory, and usually the inflammation is controlled by regulatory T cells. So that sort of control is lost, or there is an imbalance between this response that favors the the whole system is favored towards an inflammatory response. So that results in the pathogenesis of inflammatory bowel disease. And definitely there are many environmental factors. The diet, as I have told you, stress, NSAIDs, smoking, antibiotics in early childhood, and enteropathogens like Mycobacterium paratuberculosis. So all these have been found to increase the leakiness of intestinal epithelial cell, IEC intestinal epithelial cell. So it finally results in leaky gut. So in inflammatory bowel disease, what result is a leaky gut. So all these factors are cumulatively responsible in the pathogenesis of inflammatory bowel disease. So as I told you, there is an imbalance between pro-inflammatory and anti-inflammatory cytokines. So regarding the pathology, this is the gross specimen of an ulcerative colitis. As you can see, there are it is grossly ulcerated. There are multiple small nodules seen. So the gross ulceration is the hallmark of ulcerative colitis, and here it is only mucosal inflammation, unlike Crohn's disease where you have transmural inflammation. And here you can see the whole of the colon is involved. There are no skipped areas. It is a continuous involvement. So that is also a hallmark of ulcerative colitis. In the right side, you can see the histopathology. So there you can see a marked inflammatory response. You can see erosion. The elongated structures are crypts. So there are crypt irregularity and crypt atrophy is well seen. And basal plasmacytosis, that is towards the basal side, the plasmacytes are more. So it is basal plasmacytosis. So these are all features of ulcerative colitis. So coming on to the clinical features. So basically the patient presents with bloody diarrhea and loose stools. There will be passage of mucus, and the patient may complain of lower abdominal pain or abdominal cramps. Cramp is sort of pain. There will be tenesmus. Tenesmus means there will be incomplete evacuation, and there will be pain while passing motion, and there will be incomplete evacuation. That there will be feeling of urgency to pass motion, and even after passing motion, the patient will say that he doesn't feel complete. He wants to go to toilet again and again. So that feeling is tenesmus. Regarding the types of ulcerative colitis, there are proctosigmoiditis, that is one type of presentation. Second one is left-sided colitis, that is involvement up to the splenic flexure. Proctosigmoiditis means rectum and sigmoid colon is involved. Left-sided colitis means the whole left side of the colon is involved up to splenic flexure, or it can be pancolitis involvement, that is beyond splenic flexure. Also, the inflammation is happening. So the lab investigation, what will you order when you suspect that a patient is coming to you with ulcerative colitis? So I'll check for hemoglobin to see for anemia, because the patient is passing blood in stools. So he is losing blood, so that means his hemoglobin should come down. And when the hemoglobin is coming down, the platelet will increase. There will be a reactive thrombocytosis. The ESR will be high because of the inflammation, and CRP, because of the inflammation, CRP is also bound to be high. What about the stool routine? So the patient is passing mucus and blood, so we can see that in the stools, and we'll be able to see if there is any associated bacterial infection going on. So dysentery, first presentation of ulcerative colitis may mimic dysentery as well. So it helps in resolving that diagnostic dilemma as well. So regarding fetal calprotectin, so that is an inflammatory molecule that has been recently developed. So usually fecal calprotectin more than 50 is suggestive of inflammatory process going on. So if you want to find out whether an inflammatory bowel disease is in remission, so you can always do fecal calprotectin. And in active disease, definitely fecal calprotectin will be elevated. So it has a high sensitivity and specificity for detecting inflammation. In case of severe colitis, we prefer to do a sigmoidoscopy first, because if we insufflate too much air in an acute severe colitis, which I will be coming on in the later slides, there is a high risk of perforation. So initially we'll be doing an unprepared sigmoidoscopy to assess the colitis. Then we will go for a full-length colonoscopy as needed. So regarding the role of P and K, there are two main molecules involved. One is ASE, anti-Saccharomyces cervical antibody, which is found to be positive in more of Crohn's disease patients, and P and K is found to be positive more in ulcerative colitis. So there is a bit of overlap as well. And this is the score, 2-Lowitz score for assessing severity of ulcerative colitis. So one is bloody stools, more than 6 per day is severe. High fever, more than 37.5 degrees, severe colitis. Tachycardia, more than 90 per minute is a feature of severe colitis. Anemia, usually HB less than 10.5 is seen in severe colitis, and ESR more than 30, and endoscopic appearance of spontaneous bleeding and ulcerations are all features of severe colitis. So this is a colonoscopic appearance of severe colitis. You can see that white patch is ulcers, the red is spontaneous friability, erosions and ulcers. So this is a colonoscopic appearance of severe colitis. Regarding the complications of ulcerative colitis. So this is toxic megacolon. So this is usually seen in severe colitis. So this is one of the reasons why we are not doing colonoscopy initially. So I said we will be doing sigmoidoscopy, and if needed, we will be proceeding on to colonoscopy. So we will be in a acute severe colitis. We will be doing a sigmoidoscopy in an unprepared colon because of the fear of toxic megacolon. In an the X-ray shows dilated bowel looks more than 6 centimeters. That is suggestive of toxic megacolon. We should be extremely careful in such cases. They may require operative management as well. So electrolyte imbalances. Since the patient is losing blood and is having diarrhea, there can be loss of potassium. So that has to be corrected. There is a risk of perforation. So if there is perforation, there might need surgical interventions. There can be catastrophic bleed from the ulcers. There is a possibility of strictures as well in long-term ulcerative colitis, but strictures are more common in Crohn's disease compared to ulcerative colitis. Then in long term, there is a possibility of carcinoma colon. So CA colon is found to be, the prevalence of CA colon is found to be higher in IBD patients, especially in ulcerative colitis than normal population. So this is a summary of the clinical presentation. So there can be gross blood in stool, mucus can be there. There can be systemic symptoms like fever, malaise. There can be abdominal pain, and occasionally they may present with stricture and obstruction. That is rare, more seen in Crohn's disease. Endoscopically, there is continuous involvement, unlike skip lesions in Crohn's disease. And radiographically, also there can be toxic megacolon in acute colitis. So we have to be careful about that. So regarding the extra-intestinal manifestations. So not only intestine, there are many other sites other than the intestine which is involved in inflammatory bowel disease, as is an autoimmune disease. So mostly it is in HLA-B27 positive patients. So dermatologic involvement is mainly erythema nodosum, which correlates with the clinical activity. Erythema nodosum appears as tender reddish nodules. So they are quite painful. So we have to identify this and correlate it with the clinical activity. Then there is pyoderma gangrenosum that can be seen as giant ulcers in the back of on shins or back of leg. Then there can be aphthous ulceration. There can be pyostomatitis vegetans. There are many dermatological presentations of ulcerative or of IBD. Then the rheumatologic manifestations include peripheral arthritis. So it can be oligoarticular, less than 4 joint involvement, or it can be polyarticular, more than 4 joint involvement. This oligo or polyarticular arthritis correlate with the activity of the disease. Then there can be ankylosing spondylitis, AS is ankylosing spondylitis. There can be joint stiffness, predominantly in the cervical or in the lumbar disc. There can be ankylosing spondylitis. Then sacroiliitis can be there. Then the ocular manifestations include uveitis, episcleritis, and scleritis. Episcleritis usually correlates with the activity. Hepatobiliary manifestations include fatty liver, gallstones seem to be higher in IBD patients. Then there is an association between primary sclerosing cholangitis and ulcerative colitis. So the number of PSC patients having ulcerative colitis is found to be higher, and the vice versa is also true. There can be coexisting autoimmune hepatitis as well. The urologic manifestations include the development of predominantly oxalate stones. So that has to do with the defective calcium absorption in inflammatory bowel disease. That is seen mainly in Crohn's disease patients. Metabolic bone disorders like osteoporosis is common in inflammatory bowel disease. Thromboembolic phenomenon like the deep vein thrombosis and pulmonary embolism are found to be commoner in IBD patients compared to the normal population. Cardiopulmonary disorders include cardiomyopathy. There can be pleuropericarditis. There can be development of pleural effusion as well. Minimal pleural effusion can also be seen. Then rarer manifestations include amyloidosis. Then coming on to the management of ulcerative colitis, in mild to moderate ulcerative colitis, so this is a pyramid. So it can be a step-up approach or a top-down approach that varies from person to person. So this is the step-up approach of pyramid. Mild to moderate ulcerative colitis, we start with 5 ASA compounds, which can be oral compounds or topical preparation, which include rectal preparations, or it can be glucocorticoid, which can be oral or rectal. Then 6-mercaptopurine or azathioprine, which are the immunomodulators. Then we come on to the biologicals. That is infliximab, adalimumab, golimumab, vedolizumab. So I'll be coming on to detail in the coming slides. Moderate to severe ulcerative colitis. We can start with glucocorticoid, oral or IV. Then if not responding, we can go to 6-mercaptopurine, azathioprine, infliximab, then to cyclosporin and the biologicals. So coming on to acute severe colitis. So this is a very severe presentation. There will be severe bloody diarrhea more than 6 per day. So all the criteria that I have shown in the clinical features slide that applies here. So we have to find out whether the patient is having anemia and do anemia correction. Then electrolytes have to be corrected. IV steroids has to be started immediately after confirming it is acute colitis, acute severe ulcerative colitis. Usually the dose is IV hydrocortisone 100 milligram 6th hourly or 8th hourly. Then we go for antibiotics. This is usually ciprofloxacin or metronidazole or combination accordingly. Then we give IV heparin for anticoagulation. Usually 5,000 units of heparin 8th hourly or 6th hourly, or we can use low molecular weight heparin 0.6 ml sub-Q OD or PD depending on the weight and renal parameters. If the patient is not responding, we have scores like Oxford and Swedish score. We reassess, and if the patient is not getting better, or if he or she is not responding, then we go for rescue therapy, salvage therapy, or surgery. So the rescue therapy mainly involves the usage of cyclosporin or 6-mercaptopurine or biologicals like infliximab, adalimumab. And if the patient is not responding, then they'll be taken up for surgery. So this is the flow chart of how to manage acute severe colitis. So you hospitalize, admission, that is the first step. Then we start with oral or IV glucocorticoids. If the response is good, then we taper off steroids, maintain the therapy with 5 ASA compounds, and depending on the response, we try to add 6-mercaptopurine or azathioprine. And if successful tapering is possible, then continue on maintenance therapy. If unsuccessful in tapering, then more prolonged taper, more steroids are given for a longer time, and then add 6-mercaptopurine or azathioprine, and try to maintain with mercaptopurine or azathioprine. So this is usually the case with steroid dependent patients. Then if the response to steroids is poor, then IV glucocorticoids is continued for a longer period, for more than 10 days. Then if it is showing good response, then we convert to oral steroids and tapering with 5 ASA compounds or mercaptopurine and azathioprine. If poor response, that is seen in steroid dependent or steroid refractory cases, then we try to bring in cyclosporin infliximab. So if not responding, then go for surgery. If responding, then try to add an immunomodulator so that we can taper off steroids early. So prolonged steroids is not good. So we try to taper off steroids and we try to add the immunomodulators like cyclosporine and mercaptopurine. So we try to do that and maintain on 6 mercaptopurine, azathioprine or vedolizumab and discontinue cyclosporine within 6 months and continue on azathioprine. So coming on to the molecules one by one, 5-ASA compounds is one of the most frequently used compounds. So 5-ASA is the active moiety. It is linked to sulfapyridine by diazo bond. The diazo bond is usually cleaved by colonic bacteria and 5-ASA compound is released. So that acts on the colonic epithelium and produce all the effects, all the immunomodulatory effects. So the adverse effect is sulfur allergy, nausea, vomiting, rash, hemolytic anemia, folic acid deficiency, azoospermia. So this was the case with older compounds. So now newer compounds including mesalamine, they have only 5-ASA compound. They do not have the sulfapyridine molecule. So there is no worry regarding sulfur allergy. The other forms include topical forms, enema, topical or mesalamine enema is available. Mesalamine suppositories are available. So that is also available in various strengths like 1 gram, 2 gram. The mesalamine is usually available in 400, 800 milligram, 1.2 grams. So these are the strengths that are available. So this is the preparation, regarding preparation. So sulfasalazine, 500 milligram, then balsalicide, delayed release, including mesalamine, 400, 800, 1.2, controlled release mesalamine is available, and delayed and extended release is also available. So regarding the adverse effects, nowadays we are using sulfur-free 5-ASAs. So a few of the side effects include headache, there can be drug fever, rash, paradoxical disease exacerbation. Pancreatitis is a possibility with 5-ASA. So we have to be very careful with the pancreatitis. So once the patient develops pancreatitis, it becomes very difficult to restart him or her on 5-ASA. Then there can be hepatitis, pericarditis, pneumonitis, nephritis. So secretory diarrhea is seen with all salicine. Regarding glucocorticoids, prednisolone and budesonide are the most commonly used glucocorticoids. Prednisolone is usually used in 40 to 60 milligrams per day strength. Budesonide is 9 milligrams per day, so that is also weight based. There can usually the patients can be steroid responsive, dependent or refractory. If steroid responsive, then we can easily taper off the patient within 3 months of steroids. If steroid dependent, then we may not be able to taper off steroids in 3 months' time. If it is steroid refractory, we may not be able to control the symptoms on steroids, and we have to look for alternative molecules. So in steroid dependent and steroid refractory cases, we prefer to use biologicals if the other factors are favorable. So the classic side effects of glucocorticoids include sleep and mood disturbances, acne, striae, hirsutism, adrenal suppression. So adrenal suppression can lead to hypotension. There can be proximal myopathy, glucose intolerance, so diabetes can worsen, hypertension, narrow angle glaucoma, cataracts, pseudotumor cerebri, infection, edema, impaired wound healing, growth retardation, bone loss and osteoporosis is also a direct complication. There can be aseptic necrosis of the bone. So that can also lead to fractures. Regarding budesonide, there are ileal release compounds and multimatrix compounds. So that is a safer option compared to prednisolone. The adrenal suppression is a complication at dose of 9 milligram per day, but occurrence of classic glucocorticoid adverse effects are similar to placebo. So regarding the other glucocorticoid, budesonide is a safer option. So regarding the immunomodulators, there are mainly 2 molecules, azathioprine and 6 mercaptopurine. So how does it act? Azathioprine is usually converted to 6 mercaptopurine and by HPRT enzymes and IMP dehydrogenase enzymes. Finally, it is convert to 6-thiaguanine, and via the TPM pathway, it is converted to 6-methyl-mercaptopurine and its metabolites. So the 6-thiaguanine is the active moiety, so that is responsible for the immunomodulatory activity. It has the anti-inflammatory properties. So the 6-methyl-mercaptopurine has the anti-inflammatory property, as well as there is a risk for myelotoxicity. Bone marrow suppression is also there, and hepatotoxicity is also there. So that is a side effect of azathioprine. It is usually given in dose of 2 to 2.5 milligram per kg per day. And regarding 6-mercaptopurine, it is given in dose of 1 to 1.5 milligram per kg per day. So that is also similarly metabolized to 6-mercaptopurine to 6-thiaguanine and 6-methyl-mercaptopurine. The pathway is similar. So both are immunomodulators. So these are the alternatives for steroids for long-term maintenance. That is the importance of these molecules. So the main adverse effects are nausea, drug fever, rash, arthralgia, leukopenia, thrombocytopenia, bone marrow suppression, pancreatitis, hepatitis, infection, and lymphoma. So the important thing is we have to monitor complete blood count every weekly for the first month, then every 2 weekly for the next month, then monthly. Complete blood count, because myelosuppression is a very common side effect and dreaded side effect of these molecules. So we have to keep a strict vigil for these side effects, and we have to monitor liver function tests as well. So the patient is complaining of pain, abdominal pain on azathioprine, we have to be very careful that it is not pancreatitis. We have to see for pancreatitis, and if a patient develops pancreatitis, it is not at all advisable to put him on azathioprine again. So previously we used to do 6 TPMT assay before starting azathioprine, but now that is not in recommendation. It is not advisable because patients with low TPMT levels were found to have azathioprine toxicity because of the high 6-thiaguanine molecules. But nowadays we are not doing that. The TPMT mutations are much lower in our population. So regarding calcineurin inhibitors, so there are cyclosporin and tacrolimus. These are the main molecules. So they are also commonly used in transplant. So here also they have a role. So they inhibit the interleukin level. There is mainly interleukin level inhibition. It is an anti-inflammatory drug. So cyclosporin, cyclosporin and tacrolimus act via cyclophilin and FK binding protein. So there is nuclear factor kappa B expression changes leading on to the anti-inflammatory effects. Cyclosporin is initiated as 4 milligram per kg IV infusion. We have to be very careful in patients with low cholesterol levels, because that can precipitate seizure in such patients. We have to be very careful. There can be electrolyte disturbances like hyperkalemia, and renal function should be monitored, because the nephrotoxicity is also a dreaded side effect of cyclosporin. Usually cotrimoxazole is co-administered in cyclosporin patients because there can be pneumocystis cerevisiae pneumonia infection in cyclosporin administered patients. Tacrolimus, usually the dosage is 2 milligram, 4 milligram per day. The adverse effects are similar for both cyclosporin and tacrolimus. They include reversible or irreversible decline in renal function, hypertension, tremor, headache, paresthesia, seizure, gingival hyperplasia, hypertrichosis, hepatotoxicity, infection, and lymphomas. So these are some of the side effects of calcineurin inhibitors. So coming on to biological. So the biologicals have revolutionized the treatment of inflammatory bowel disease. So there are many molecules, biological molecules available in our armamentarium against the fight towards inflammatory bowel disease. So a few molecules are anti-TNF alpha molecules, include infliximab, adalimumab, certolizumab, and golimumab. Anti-integrins include natalizumab, vedolizumab. JAK inhibitors are tofacitinib. They Tofacitinib acts mainly against Janus kinase 1 and 3. Anti-interleukin 12-23 include ustekinumab, which was previously used in psoriasis. Now it has been useful in inflammatory bowel disease as well, because interleukin 12 and 23 are pro-inflammatory cytokines. And I hope you remember the pathogenesis where I had told that interleukins 12-23 they are pro-inflammatory molecules. So anti-interleukin 12 and 23 are is ustekinumab, and it is useful in inflammatory bowel disease. Ozanimod is a sphingosine 1 phosphate inhibitor. They inhibit the lymphocyte trafficking, and that is another molecule available in the fight towards inflammatory bowel disease. So regarding infliximab, it is an anti-TNF alpha inhibitor. It is usually given as infusion 5 milligram per kg IV. So there are many trials that prove the efficacy of infliximab. It is usually given as 5 milligram per kg IV IV infusions. So the efficacy has been proven. So the next one is adalimumab. Adalimumab, the dosage is weight based. Usually in IBD we give it as 160 milligram, that is subcutaneous, 160 milligram, followed by 80 milligram after 2 weeks, and then 40 milligram every other week we continue. So there has been studies with adalimumab being given for 1 month, 3 months, 6 months. So it has been found to be better than placebo in controlling the and in controlling the inflammatory disease process. Then there are certolizumab and golimumab, which is not widely available in India. We mainly use infliximab and adalimumab. So regarding the natalizumab, it acts on both alpha 4 beta 7 and alpha 4 beta 1. It is an integrin, anti-integrin. So it acts via the MADCAM, cellular adhesion molecule level. So natalizumab acts on both alpha 4 beta 1 and alpha 4 beta 7. So alpha 4 beta 1 is present in brain. So one of the side effects of natalizumab was progressive multifocal leukoencephalopathy in patients with JC virus. So previously, before development of vedolizumab, we used to check for JC virus, and if it is absent only, we used to give natalizumab. Now vedolizumab is available. It has more specific action. So it acts specifically on alpha 4 beta 7 integrin, thereby controlling the trafficking of neutrophilic and lymphocytic trafficking by inhibiting the MADCAM1. It is cellular adhesion molecule 1. So that is how it acts. It exerts its anti-inflammatory action. So tofacitinib, it is available in 5 milligram and 10 milligram doses. So that is also available now. So regarding biosimilars, so all these original molecules are costlier and in a resource poor setting like ours, so we usually prefer biosimilars. So biosimilars, they have a slight differences in the compound, but the efficacy is similar. So that is why we call it biosimilar. So in adalimumab, our biosimilars include Exemcia. So in infliximab, there is Remicade. There are many biosimilars available. So it is slightly different from the original molecule of innovator brand, but the efficacy is similar. So it is less costly, and we use biosimilars. So these are the side effects of anti-TNF antibodies. Before starting on anti-TNF alpha, antibodies like infliximab, we have to do a thorough check for tuberculosis, like Mantoux test, chest X-ray or CT of the chest has to be done, because if there is TB, there can be a flare up of TB, and they have to be vaccinated prior to starting these antibodies, because there can be severe immunosuppression associated with. So we usually vaccinate with hepatitis A, hepatitis B, varicella zoster, MMR, the vaccine, and pneumococcal and influenza. We vaccinate against all these things, and then we start on anti-TNF molecules. So side effects include upper respiratory tract infections, disseminated tuberculosis, increased risk of systemic fungal infection and other intracellular pathogens, acute or delayed hypersensitivity reactions, anti-nuclear antibodies, anti-double-stranded DNA antibodies, lupus-like reaction, demyelinating disease, and these molecules can develop antibodies to itself. So there can be anti-TNF antibodies, the anti-infliximab antibody, anti-adalimumab antibody, those sort of things can also happen. Then one of the major problem is development of lymphoma. It can be non-Hodgkin lymphoma or a hepatosplenic T-cell lymphoma. So that is also a very dreaded complication associated with anti-TNF antibodies. It is contraindicated in heart failure because of increased mortality observed in various studies. So natalizumab had, as I told you earlier, progressive multifocal leukoencephalopathy, headache, flushing, infections, jaundice, liver failure is associated. Vedolizumab, nasopharyngitis, upper respiratory infections and headache. Ustekinumab is associated with upper respiratory and other systemic infections, headaches. So this is an overview of how to manage mild colitis. So if the patient presents with mild colitis, if it is a rectal involvement or it is a proctosigmoidoscopy, proctosigmoiditis, we can start with topical preparation or oral preparation of 5 ASA compounds. If it is good response, we can just maintain with 5 ASA. If it is poor response or if the extent is more, like if it is left-sided colitis or pancolitis, then we have to add on glucocorticoids. And if it is showing good response, then we taper off steroids and we try to maintain them on immunomodulators like azathioprine or mercaptopurine. As I told you earlier, it's not good to put a patient on steroids for longer times. It has more severe adverse effects. So if patient is not responding to oral glucocorticoids, then we add on IV glucocorticoids along with azathioprine or 6-mercaptopurine, the immunomodulators. If it is showing good response, then we taper off steroids and maintain them on 5-ASA compounds and immunomodulators. If it is showing poor response, then we consider adding rescue therapy, cyclosporine, infliximab, and add the biologicals and taper off them and maintain on immunomodulators. So if it is not responding to all the medical measures, then we go for the surgical option. So there are a few other things that I would like to discuss regarding the role of probiotics in IBD. So there are various studies with multiple strains of Lactobacillus bifidobacterium. So BSL-3 has a few studies have shown benefit in controlling the inflammatory process in IBD. That is with BSL-3. There are a few studies. Then antibiotics, metronidazole has been shown to control the disease process, long-term metronidazole administration. So there are not many studies validating it, but there are a few studies. So fecal microbiota transplantation has come up in a big way. So it has been found to induce remission in a few patients with inflammatory bowel disease. There are many articles available widely that is showing efficacy of FMT. So if it is not responding to the molecules, then we go for fecal microbiota transplantation and see the response. So that is coming up in a big way. So it is not only useful in inflammatory bowel disease, it has been found to be useful in many other cases like severe alcoholic hepatitis, in non-GI. There has been many studies going on with in non-GI conditions like Parkinson's, Alzheimer's. There are studies going on, but there are no definitive proof. But we have found it to be useful in severe alcoholic hepatitis and inflammatory bowel disease in controlling remission. Then regarding elemental diet, complete enteral nutrition with elemental diet using the basic molecules has been found to be useful in maintaining remission in inflammatory bowel disease. So when to do surgery? That is a very important question. So when there is development of CA colon or colonic dysplasia, high-grade dysplasia in a large extent, then we go for surgery. If there is colonic perforation or if the patient is having growth retardation, so that is more common with Crohn's disease than ulcerative colitis. There is intolerable or unacceptable side effects due to medical therapy, or if it is a medical refractory disease, we go for surgery. Then if there are systemic complications that are recurrent or unmanageable, then we go for surgery. Then as I told you earlier, toxic megacolon or uncontrollable refractory colonic bleed, we go for surgery. So what surgeries do we use commonly? So in picture A, you can see an ileostomy. We have done a total colectomy. The rectal stump is remaining, so that's a Hartmann's pouch. In B, you can see a total proctocolectomy, and there is an ileorectal anastomosis. In C, you can see an ileostomy. The whole colon is removed. In picture D, the ileostomy is a continent one. It's a continent ileostomy. In picture E, you can see proctocolectomy has been done, and there is a pouch that is an ileal pouch anal anastomosis. Ileum is joined with the pouch. Rectum is made in the pouch, and that is seen as ileal pouch anal anastomosis. So regarding the colonoscopic surveillance, so if the patient is having only proctosigmoiditis, there is no need for the surveillance. So if the patient is having left-sided colitis, we go for 12 to 15 yearly colonoscopic surveillance as needed. So if the patient is having recurrent symptoms, we need to go in again and again. Otherwise, it's needed only 12 to 15 years. If there are no activity, then we can proceed accordingly. In pancolitis, we go for second colonoscopy after 8 years if there are no further complications, or else then we go in every 1 to 3 years depending on polyps and the dysplasia. So we have to manage accordingly. Regarding fertility and pregnancy, ulcerative colitis in activity, pregnancy is not advisable. So once the patient goes in for remission for at least 6 months, both clinic, that is remission includes clinical remission, inflammatory markers, that is biochemical remission, endoscopic remission, and histological remission. If all this is attained, then the patient can proceed with pregnancy after attaining remission for at least 6 months. Regarding fertility, previously the ASA compound, when it included sulfur, there was azoospermia, but most of the 5 ASA compounds now are do not cause much of the problems, and many of the molecules are not safe in pregnancy. So when the patient becomes pregnant, we usually switch to 5 ASA compounds or steroids as according to the patient. Azathioprine, it is a category D drug, so there are recommendations that we can continue using azathioprine in pregnancy, but most of the routine practitioners switch to steroids when the patient becomes pregnant. And usually, if the disease is in remission, then the pregnancy is found to be uneventful. Then these are the few take-home points I would like to give. It is very essential to understand the pathophysiology, as it is not at all a rare disease, it is pretty common. So a thorough understanding of the pathophysiology is important in knowing which medicine to pick and which medicine to choose and which medicine to administer. So recognizing early, there are many differential diagnoses for ulcerative colitis. So it's very essential to recognize that this is ulcerative colitis and not other things. So we have to pick it up early, and the treatment should be started early, and it should be customized according to patient. Not all patients have this are administered the same molecule. Some may need to be started on steroids, some may need to be started on biological. So that should be customized, and each patient should be taken as a different case and treated accordingly. So that's all. Thank you all for your very patient listening. Thank you.
Thank you so much, sir. Thank you for delivering such an informative and elaborative session on ulcerative colitis. So we have received a few questions via YouTube Live and the previous registration form. So can we take a few of them?
I know it was a very extensive session, but it was a very extensive topic as well. That's why.
So the first question is from YouTube. The participant is asking, what is the association of ulcerative colitis and multiple sclerosis?
Okay, yeah, that is a very good question. Uh, uh, Ulcerative colitis is usually a Th2 dependent disease that is in pathophysiology. So it is a T cell mediated disease and it is an autoimmune sclerosis. So the process is similar in multiple sclerosis. That is also T cell dependent disease. So it is found that the patient with multiple sclerosis have uh, associated IBD that is seen. So if you are asking me, there is a higher incidence in IBD and in yeah, if there is a higher incidence of IBD in patients with multiple sclerosis, then there can be, but it is not as high compared to other autoimmune disorders. Both are autoimmune disease, so the incidence are higher in patients with multiple sclerosis.
Okay, thank you, sir. So my next question is, some studies have suggested that children of below average birth weight who are born to mothers with ulcerative colitis have greater risk of developing the disease. Can you please throw light on this point?
Yeah, yeah. So as I told you, there are genetic susceptibility. There are genetic factors that make a person susceptible to the development of inflammatory bowel disease. So there are many genes like NOD2, CAR15 genes, ATG genes, interleukin 23 receptor genes. So there are many umpty number of genes that are present. So there is a hereditary component to it. So if a patient has a history of IBD in her parents, in his or her parents, then there is a high chance that he may get the disease. Yeah.
Thank you, sir. The next question is from YouTube. The participant has asked, can you please mention a few drugs which can cause ulcerative colitis?
Yeah. So a few drugs include antibiotics like amoxicillin, clavulanic acid. That has a higher incidence of Clostridium difficile colitis as well. So that precipitates uh, IBD exacerbation. Then NSAIDs are a very common culprit. So many over-the-counter pain medicines are found to be culprit, and many Ayurvedic many camps, complementary and alternative medicines are also found to be uh, uh, provocating the IBD process.
Okay, thank you, sir. The next question is, can you please explain what happens to serological markers like ANCA, that is anti-neutrophil cytoplasmic antibodies, and anti-Saccharomyces cerevisiae antibodies, that is ASCA, in ulcerative colitis?
Yeah, so I had explained that previously. So let me come to that again. In Crohn's disease, it is found to the levels of ASCA are found to be higher, uh, as shown in a few studies. So I think it's the number is around 60 to 70%.
Kuldeep, I'm unable to hear, sir.
I
Is it
guess
an issue
there's
at
some, yeah, there's some technical issue with our speaker.
contacts are back? So I would request all our participants to kindly be patient and stay tuned. Sir is joining in a moment, so I would request all the participants to kindly have patience. Thank you so much.
Am I audible now?
Yes, sir. You're
Yes, sir,
audible.
you're
There was a power cut, so I lost all the connections. So I was telling that see ASCA, the levels of ASCA, anti-Saccharomyces cerevisiae antibody is found to be higher to the tune of 60 to 70% in Crohn's disease patients, and the numbers are similar. That is around 70% patients with ulcerative colitis are found to have P-ANCA positivity.
okay. Thank you, sir. So the next question is from a registration form. The participant has asked, why do the patients who have undergone appendectomy have low incidence of ulcerative colitis?
That is a very good question. So I do not know the answer. So it has been found in various studies, various studies, that the incidence of patients post appendectomy trials were conducted over a large time period. So it has been found that patients post appendectomy are found to have lower incidence of ulcerative colitis. Uh, but the reverse is not true. With Crohn's disease, that's not true. So I'm not sure with the answer. It is found to be true. That is a very good question.
Thank you, sir. The next question is, what is fasciitis?
Sorry?
What is fasciitis?
Okay, pouchitis. Yeah, pouchitis. So, yeah. So I have shown you a picture of ileal pouch anal anastomosis. So that is a surgery for ulcerative colitis. So we develop a pouch so that the patient can pass motion according to his will, and we prevent him from having a colostomy. But there is a risk that uh, the ulcerative colitis can recur again. So that is a risk associated with pouch. So what happens is sometimes uh, we have to disconnect the pouch before attaching the small bowel to the rectum. Sometimes if the rectum is inflamed, we have to keep it in isolation. So there will be an ileum going in as ileostomy, and there will be a pouch, Hartmann's pouch I have shown in the slides. So the pouch gets deprived of the uh, nutrients, and it can be uh, it becomes devoid of the nutrients, that is colonic nutrients like short chain fatty acids, butyrates. So the pouch gets the colon gets deprived of the nutrients, and they become ulcerated and they get inflamed. So there can be development of diversion colitis. And the pouch itself can get inflamed, and there are various treatments available for pouchitis like rifaximin, ciprofloxacin, metronidazole. And it is very important to identify the pouchitis early. Otherwise, we have to go in for, like how we were. I have shown you the various slides in the treatment of ulcerative colitis. So according to the severity, we will have to treat either with steroids or with immunomodulators or with biologicals. So if we are not identifying it properly and early, and the patient might have to be transferred to a colostomy.
Okay, thank you, sir. One participant has asked, does the consumption of milk lead to or exacerbates the symptoms of ulcerative colitis?
Yeah, okay, that's a good question. So cow's milk protein allergy. Uh, I would like to highlight that point now. So cow's milk protein allergy has been found to exacerbate the symptoms of IBD in a few subset of patients. The other thing is the regarding hygiene hypothesis. So in hygiene hypothesis, what happens is the patients who had enteral infections like dysentery, like small diarrhea in childhood, multiple episodes of diarrhea, asthmatic episodes, for infections in childhood are found to have lower incidence of inflammatory bowel disease in future compared to those who are living in a protective environment, like those who are confined to the house. They have not got any respiratory infections or bowel related infections in childhood. They are found to have higher risk of inflammatory bowel disease. But cow's milk as an allergen has been found to increase the risk of inflammatory bowel disease in a few studies, but that is separate from cow's milk protein allergy. Both are not the same.
Okay, thank you, sir. So there are a few more questions. Can we take them?
Yeah, sure. Okay, fine.
Okay, so the next question is, in case of remission of disease, will steroids be equally useful?
Sorry, pardon?
In case of disease remission, can steroids be used? Like, will steroids be useful in that case?
Okay. There are basically two things. One is activity and one is remission. Okay. So in active disease, so we use steroids. If not responding, we use biologicals or rescue therapy. So that is inactivity. The patient is having activity. So we try to bring the patients with having activity into remission. So we are bringing it into remission. So once the patient reaches remission, so there is no need to continue the patients on steroids. So I have stressed that point over and over again. So the patient should not be maintained with steroids on remission, because the side effects of steroids are too large. The range is too wide. I've shown you many side effects. The maximum number of side effects belong to steroids if you count each one of them. So it is very important that the patient is not maintained on steroids. There are alternative molecules for maintaining remission, and steroid is not one of them. I hope I have made that point clear.
Yes, thank you so much, sir. The next question is, can ulcerative colitis lead to cancer?
Yes, definitely. Long periods of ulcerative colitis are found to uh, develop into, finally it goes into display. There are many steps involved. So there are formation of polyps, then there will be dysplasia, then the patient goes in for malignancy. So dysplasia can be low grade dysplasia or high grade dysplasia, then the patient goes for adenocarcinoma of the colon. So it happens in sequence.
Okay, thank you so much, sir. That brings us to the end of the Q&A session. Thank you once again.
Yeah.
I now hand over the session to Aishwarya to please deliver the vote of thanks. Over to you, Aishwarya.
Thank you so much, Kuldeep. I would like to take this opportunity to thank the speaker, Dr. Neeraj Vinayakumar, sir, for this marvelous and enlightening session. All of us gained immense knowledge through this session, and I'm sure that all of them, all of the Pharm D students as well as the medical students would be benefited out of this session during their clinical postings. On behalf of the whole Pharm D community and all the participants, I would like to thank you, sir, once again. I'm thankful to all the participants from all over the country who have joined us this evening and who attended this live session. Also, once again, I would like to thank Sir for taking out time from his busy schedule even during this difficult times of the pandemic. So thank you so much, Sir.
Thank you for having me. Thank you.
I hope these webinar series will help all of our participants to gain knowledge and also to improve their clinical practice during their postings. Also, participants, there is an important announcement. So the first assessment is scheduled on 4th of March, that is Thursday. The link will be open till 5th March, 8 p.m. The portion for the exam, that is the first assessment, is PUD, liver cirrhosis, malabsorption syndrome, chronic pancreatitis, celiac disease, and acute pancreatitis. So all the webinars, in short, it is all the webinars up till acute pancreatitis. Please make a note that the link for the assessment will be posted on the same day and it will be posted only on the Telegram groups. So I would request all the participants who are attending us live on YouTube to join the Telegram group if they haven't joined till now. Kindly note, the link will be active till 5th March, 8 p.m. And I do request everybody to join the Telegram group so as to avoid further confusion. Also, I would like to make it clear that the links would not be sent on email. So kindly make a note of that too. It is going to be on the next Thursday, and best of luck. The portion is still chronic pancreatitis, and the questions are going to be pretty easy if you have attended all the sessions. Apart from the assessments, it's it's mandatory for everybody to attend at least 80% of the lectures in the series. 80% attendance is also one of the certification criteria. Only when you complete both the certification criteria, everybody will be awarded with a certificate. Thank you so much for joining today. See you tomorrow at 11 a.m.